Okay, so good evening, everybody. Welcome to the fourth PKC webcast series. And on behalf of the organizing committee of the Pune knee course, it's a great pleasure to welcome you for the fourth webcast, which is going to be on advanced osteotomies. And it's none other than, as Sachin calls him, the magician of osteotomies around the knee, Dr. Ronald van Heerwaarden. He needs no introduction actually. He has been visiting Pune for the Pune knee course and is always so excited when I see him in Pune at the Pune knee course and the surgeries he has done, especially the last time the surgery he did on the girl for the slope modification was absolutely a fantastic treat to watch. So he's here with us today. He currently is working as a consultant at the International Knee and Joint Center in Abu Dhabi and also at the London Knee Osteotomy Center in London. But he's originally from Netherlands, where he established his Center for Deformity Correction and Joint Preservation in 2016 at the Viasana Clinic in Mill. He's also been the chairman of the ESCA Osteotomy Committee. He has written numerous books on osteotomies and deformity correction and has more than 100 articles in peer-reviewed journals on the same topic. So he is the perfect person to speak on osteotomies, and we are going to have a treat of talks today. He's going to start with the talk on advanced planning, and this will be a good follow-up to the webinar which we had on osteotomies around the knee from the Austrian surgeons. He will also speak on slope corrections for ligament laxity, something which we have started to do, and he has a special interest in that. And the difficult ones, the rotational osteotomies, and then end with something for the trauma guys also, where the knee surgeons try to put in their efforts. That is the intra-articular osteotomies for malunited fractures. Absolutely, very important four topics which are being put up, and Sachin has very properly selected the topics for Dr. Ronald. So it's a great pleasure to welcome you, Dr. Ronald, and we are looking forward to hearing your first talk on advanced planning. Over to Dr. Ronald.
Well, thank you very much for introducing me. I try to start up the screen now. You have the screen now?
Yes. Not yet, not yet. You just have to press the button down. Perfect. We have it now. Yeah.
Well, thank you very much, Dr. Parag, for the kind introduction. Thank you for the whole Pune team. I've been visiting your very, very high-level course for a couple of times now, and this year the world is different. And for all who are watching this webcast, I wish you health in these difficult times, of course. And this is the new way to teach. And this webinar series of the Pune knee course is a very high standard. So I was honored and privileged to be working with the team again now in a webinar. The first topic we're going to address is on advanced planning. And the advanced planning is more a continuation of the planning session that was beautifully given by Dr. Christian Klei, whom I work with together with Adrian Wilson, who was also in the first session on osteotomies 2 weeks ago. And also Ragbir Kaka is of great help in the London Knee Osteotomy Center. So actually I'm working in 3 centers. My only profession is deformity correction, and that's what I like most. So that's what I like teaching about too. First, we're going to start about advanced planning. Now, if we continue from the last time, the very important things already mentioned then are x-rays. If you can get a hold of an x-ray department technician who can make these kind of x-rays, long leg x-rays, that's mandatory for a proper planning of osteotomies around the knee. And if it's not possible to do that in your hospital, please find for these cases where you really want to try a good correction, specifically in advanced corrective surgeries, try to find a center in your neighborhood where they can make these x-rays. And the x-rays should be made by someone who knows how to make these x-rays. So instruct your technicians. This is on the left side an incorrect positioning with the patella not forward, but patella pointing outward. At such a position, you will not have a good x-ray for your correction planning. So you should have the patella facing forward, whatever the position of the foot looks like afterwards. Because, and we will see examples of that later on, you can have a rotational deformity of the lower leg. Then patella forward means that the foot points very much inwards. And that's if you want to correct the frontal plane, so varus valgus in such a situation, you can only refer to a patella forward view. So on the right, you see a corrected foot position with patella forward position. And that's what you always should ask for a full leg weight bearing x-ray, where you make your planning. Now, also correct for leg length. This is all illustrations out of the Bible of deformity correction by Dror Paley. You see that there's a height wooden block under the foot, and this will be important if you have leg length differences to make a good planning x-ray. Also important, any kind of ruler or calibration bullet like in this x-ray, then you have calibrated x-rays. These are the mandatory steps if you want to do a proper planning for your deformity correction. Now, you have seen this, and I will go fast. This is the analysis of the deformity according to Dror Paley. It has all been given to you already in the presentation by Dr. Klei 2 weeks ago. It is deformity analysis according to Dror Paley, and this animation has been made together with Stefan Schreuter, a good friend of mine and colleague in deformity correction from Germany. Here we are, we draw the lines, the mechanical axis are we using, and we can make angles around the knee, the mechanical lateral distal femoral angle, which normally measures 88, and the medial proximal tibia angle, which is normally 87. These two angles are very important to remember around the knee. Then you have other angles, the lateral distal tibia angle, the mechanical lateral proximal femoral angle, but we don't use these angles very often. Then you have, of course, the mechanical tibiofemoral angle, and then the joint line convergence angle. In the webinar 2 weeks ago, this was extensively explained by Dr. Klei, and I think he gave a good presentation of all the importance there. If you have an opening of the joint or an obliquity of the joint around the knee, you have to address that. You have to address that in your deformity analysis. You have to recognize it, but also address that in your deformity correction. Otherwise, you will end up with an overcorrection caused by the negligence of ligament laxities, which add to deformities. Or you will end up with a joint line obliquity because you didn't respect that besides a deformity in the tibia, there was also a deformity in the femur. Let's go to planning of an open wedge HTO. I just go fast. This is Fujisawa point planning. This is an open wedge, and you can just draw your lines and measure your angles. And I will go a little bit slower in this case. Mechanical axis of the limb, big varus. We want to go there. We want to have a weight-bearing line after the correction that passes just lateral or central to the knee. This is not much of a medial osteoarthritis. This is just a deformity. We draw our lines. We measure the angle between the old ankle center and the new ankle center. And then we project this angle on the medial proximal tibia, as this is a tibia deformity and not a tibia plus femur deformity. Then final step, if you have a calibrated X-ray, you can make a measurement on the medial side what the height is of the osteotomy gap. That's what I take into the surgery. That's what I want to know. After my planning, I know how many millimeters I have to open to correct so that the weight-bearing line will pass at the exact right point. And that will give me this correction in this patient. Anyways, from there, you can also do closing wedge distal femoral osteotomy planning. This has all been given by Dr. Klei last time, but just to show you that the same Miniachi type of planning works in the femur too. You're just gonna make a new femur center, femoral head center, and from there you draw your lines and you measure your angles, and final step, you measure the height of the wedge to take out in a closing wedge distal femoral osteotomy. Now here's the importance of deformity analysis. This is one of the Abu Dhabi practice patients, big varus, and as already stated by Dr. Klei last time, if that weight-bearing line passes outside the knee, you have to be careful. There might be a varus also present in the femur, and it is, in this case, femur and tibia. So here you see that no way that you can only correct this in the tibia, you have to correct it in the femur as well as the tibia. This was a lateral closing wedge, and the wedge taken out on the lateral side is inserted in the open wedge of the tibia on the medial side. This is the post-operative X-ray, and this is the post-operative digital picture of the patient from Abu Dhabi. Now, let's move over to advanced planning. This is the surgical plan concept. I've written about this in the years 2008, and it's based on Schatzker's book on the rationale of fracture care. And if you look in that book, you will find similar build-up of a surgical plan. I've adapted that surgical plan method to osteotomies, and since then I've worked with it, and especially in advanced osteotomies it's very important to follow such a plan. So I hope that you're interested to learn about this, and let's go over step by step. First part of the surgical plan is a physical examination. Then you have your radiological deformity analysis. And of course, the complaints of the patients and the whole history come before this, but this is for planning these are the most important steps. And the radiological deformity analysis in any plane, frontal, sagittal, as well as transversal plane. And we will see examples of that through the other presentations and through some case presentations later on in this presentation here. Very important step is to correlate physical examination and your radiological deformity analysis. You cannot have an X-ray as the only thing to work with when you start doing your surgery. We should be careful with that. If you haven't examined your patient, you cannot correlate the examination, where you might find additional ligament laxities which you cannot see on the X-rays. And if you are not doing anything to these ligament laxities, in some of these cases, the bone correction will be off, and you will have a suboptimal result for your patient. Step number 4, the definition of your deformity and also the aim of correction. In some of these patients, the aim is not to go to the Fujisawa point. There may be an aim of your correction where you only have to correct to symmetry. After a trauma, the patient just wants a leg back that's symmetric in slight varus, for example, to the other leg. So if you aim for a correction that is always in valgus because you're doing a high tibial osteotomy, that's not the good aim. So the definition of the deformity and then the aim of correction. Then you do your planning of correction. And look at number 6, implant selection. We often do not have a choice of many different implants. However, some of our deformity corrections, these patients need different implants than you normally use. There are sometimes better implants, or you need an X-fix or any kind of implant that is not standard in your hospital, you should weigh that in your whole plan and give it an important part at the end of your plan. And the final step is the description of surgical tactic. Now, what is that? Look first to this girl before I come back to the description of the surgical tactic. And we're looking now at the correlation of physical examination gait. So this young lady was sent in because she has a valgus problem. We will see her later in another presentation, but I just want to show you that this young lady doesn't have a valgus. So something else is going on. So you wouldn't know that she has a straight leg alignment only from her video. So you have to correlate things here. You have to examine, you have to look at x-rays, correlate that to your physical examination. And again, we will see this young lady later on in one of the other presentations. Now here's the surgical plan again. This was on correlation of physical examination and radiological deformity analysis. Now look at this case. This is a 54-year-old lady. She had a flexion osteotomy because she was having severe hyperextension. This has been performed many years ago. When she comes to the clinic, she is able to do a full extension of her knee. If you look at that slope of 51, and I already tell you that a normal slope is not 51, but 80, 82, 81 in this kind of measurement. So she has 30 degrees abnormal slope. Then you have to realize that if she can fully extend the knee, she still has a severe laxity problem. She still has her posterior capsule very lax. So this is out of Paley's book, some drawings of a similar case that was simulated there. And if you correlate the examination findings, having her a full extension of the knee with the deformity analysis, you realize that you have not only a bone deformity, but you also have a ligament deformity, the posterior capsule. And that's also called a deformity, a 30 degrees joint laxity compensation. So this is a osteoarthritis, which has to be treated with a total joint replacement. You better choose a hinged implant at that time. And this case, to get that implant in, we did an anterior closing wedge, hence you see the staples there, to make that plateau flat again. The minute you make that, you correct that plateau in the sagittal plane, you have a 30 degrees hyperextension back again. And for that, it's mandatory to use a hinged prosthesis. This could only be known with a proper planning according to a surgical plan. So it's very important to correlate what you see on x-rays with your physical examination as part of the surgical plan. Now, what about this point number 7, the description of a surgical tactic? Description of a surgical tactic are the final questions before you go to the surgery. Is the proposed osteotomy site surgically accessible? Like, is it full of scars? Can the plan be carried out using intraoperative guides to enhance your accuracy? Or do you need PSIs or these kind of tools to work there? Is the location of the cuts biologically reasonable? Some of these cases, specifically the post-traumatic cases, you almost do not have an entrance, or you should switch from entrance because of the soft tissue scarring, neurovascular bundles that are compromised, or previous musculocutaneous flap surgery. Is a stable fixation possible with the fixation method you choose? Normally at step number 6, you should have made your decision there, but still it's also important to check that before you go to surgery and probably have an alternative on the backhand. And then, can the soft tissues withstand the degree of bone correction anticipated? So sometimes you have to just stick with a partial correction, because it will otherwise, the soft tissues cannot withstand the total correction. And that's very rare, but if you do not anticipate on that, you will have big soft tissue problems after your correction, and the patient has the biggest problems. So these are all very important things to think over before you step in that OR and to finalize your surgical plan. Now look at this case. This was a case, motor vehicle accident, very disturbed fracture healing with also a lengthening procedure, infection, and this type of soft tissues the patient was left off with. And then he just didn't want to have any surgery for the next 5 years. And now he comes to the clinic with a medial pain, medial osteoarthritis. And he tells me, oh, by the way, my foot is pointing inwards. So what do I do? Well, if you look, you see severe soft tissue scarring. There is a rotational deformity, and there is varus osteoarthritis. You see a weight-bearing line that is in varus. So if you want to do a correction of 2 things at once, varus to slide valgus, to unload the medial compartment, and a rotational correction, how do you do that? Where do you do that? So this is just to go step by step on how you can think of a case like this. Here we go. Physical examination, normal as expected. Of course, an in-toeing gait on one side, malunited fracture in internal rotation, and also varus. Radiological analysis you have seen already, and we have the CT scan there. If we look at the correlation, we see a 10 degrees of varus osteoarthritis, 20 degrees of internal rotation deformity, and severe soft tissue scarring. We have a definition of our deformity, and this is our aim, a valgus unloading and extension, external rotation osteotomy. That's what we want to reach. How do we reach that? How do we plan that? Well, this is the situation. We have tibia proximal, shaft, distal, and where can we make our osteotomy? Proximal, on the lateral side, I don't want to go. Shaft, I don't want to go anywhere there because that's bad bone healing. And how do I correct both planes there in the presence of that soft tissue? Do we go distal? Well, distal seems reasonable because we have good soft tissues distal. However, how do we correct the varus? Why don't we think multi-level? That was the choice. And then we have also made our decisions on plate fixation, and you're going to see what we have done there. And of course, most important, we deal with the soft tissue scarring. And the final conclusion of this surgical plan was we go double level. We do a proximal open wedge high tibial osteotomy to unload the medial part of the knee for the varus osteoarthritis. And we do a distal tibia and fibula rotational osteotomy. That's where the good soft tissues are. They can withstand these kind of forces and stretching. So then I was talking to my plastic surgeon, and just to ask him, can I do this with the soft tissues? And he says, you go for a preconditioning. And I didn't know what that was. A preconditioning is you make a scar, you develop your approach until the level where you want to go, and then you close. And I say, I beg your pardon, you're going to close? Yes, you're going to close the wound again and you let it heal. And then if that's good, then you know it's vital and you can go there for a second time. So that's what we did, step number 1. And the patient was fine with that. So after 6 weeks, we did the double level osteotomy, the multi-level. And this was the result. Open wedge medial, external rotation, distal tibial osteotomy and fibular osteotomy, and plate fixation at 2 levels. And this is the result at the end of the surgery. So this is surgical planning. This is advanced osteotomy planning. And this is just an example of many of these cases who need this extra kind of planning. Now, there also is a need sometimes for complex x-rays. You can all find that, how to do with that, deal with that in the book of Paley, who has excellent descriptions and illustrations of that. Just an example. This is a case of post-traumatic and congenital deformity combined. This patient deformity is in an oblique plane. Actually, that's the case in many road traffic accident malunions in lower legs. So you have to be careful that you analyze all the planes. And this is just an example how with x-rays you can find the plane where you need the correction to be performed. But you need to make specific x-rays. And these are specific x-rays to find which plane shows a straight bone. From that, you can find the plane of your correction. So here we are, the oblique plane. And the oblique plane deformity gives you a straight bone. And from that, you can make your osteotomy plannings. And I'm not going to go very, very deep into that, but you have to realize that these oblique plane deformities exist. This is an example and how you can correct it with an oblique osteotomy. We have a combined valgus and external rotation tibial deformity. And there on the lower left corner, you see the planning x-ray. This is an oblique plane osteotomy. The ruler you will see later on in the rotation osteotomy talk, and we make an oblique plane ending underneath the tuberosity, and then while internally rotating the leg, we immediately also correct the valgus. And after that, we do a, and you see the K-wires here, 18 degrees off, and after the rotation, you have a straight leg with the K-wires in the same plane. So both deformities are corrected by one movement. And you can only find out how to do that when you make these oblique plane x-rays. Now you can go from peri-articular to shaft deformities, and there's also CORA and the osteotomy rules. That is not part of this presentation. We are talking about other kind of deformities, especially at the shaft level, but I want to mention that sometimes in multi-level deformities, you have to be aware that you have to deal with a combination of peri-articular deformity as well as shaft deformities. And then rules like osteotomy rules, CORA, and ACA, angulation correction axis, play a very important role. So you have to think of your knowledge on that topic if you have multi-level deformities. Take-home messages on advanced planning. Full leg weight-bearing x-rays are mandatory for planning, and please put the patella forward. Deformity analysis according to Paley is recommended. The manual planning according to Miniaci, which has been taught to you by Dr. Christian Klei last session, the webinar 2 weeks ago, is recommended. We describe these plannings in all our books and all our publications. Planning of an open wedge and a closed wedge is possible at the femur and the tibia, and deformity analysis always before planning to find the location of correction. Planning is more than repositioning weight-bearing lines. I hope that's very clear now. Make a surgical plan, especially if this is an advanced case with soft tissue issues bothering you. Correlate physical examination with your radiological deformity analysis and look at the joint line orientation. And the planning with ACA and CORA is a planning which is most important when you have shaft deformities. Finally, plan every case and evaluate your planning. So this is to the first topic, advanced planning.
Excellent, excellent talk, Dr. Ronald. That was just mind-blowing. Any questions from the panelists first, and then we'll open up. We are getting some WhatsApp questions also, Dr. Ronald. So
yes, Anshu, I think you have a question. Can you come in with your question, please?
Yeah, my question is, there was one double osteotomy, double level osteotomy X-ray that you had put up, and for the lateral distal femur osteotomy, you had used the plate which we normally use for the medial closing wedge osteotomy, the Tomofix plate.
Yep.
So
yeah.
Your plate selection for the femur, how does it go? Is it depending on the whether it's closing or opening, or whether you decide based on if it's medial or lateral?
Well, thank you for the good question. And of course, Dr. Ansu, you are experienced, so you saw that sometimes I use plates off-label, as we call it. So sometimes I use a plate which is originally designed for medial distal femoral. I use it for lateral distal femoral because the dimensions of the bone are such that a bigger plate is not necessary. That's the first one, and also causes too many complaints for the patient. So I choose another plate, and that's exactly in the surgical planning, the advanced planning, what you're thinking of. Is this a small stature person? Is this a lady who will have a functional problem with exercise and rehabilitation when I use a big plate? So I choose the plate, the kind of fixation, dependent on the patient, and of course on the soft tissue situation, and then in the whole plan, with scarring or no scarring, I decide which side of the bone, opening wedge or closing wedge, I'm going to take. So I hope this answers your question.
Yeah, so Nilesh, you have a question coming in?
Yes, so am I audible?
Yes, you are.
Yes.
Right, good evening. So my question was that for the preoperative planning, would you get a standing scanogram only in the AP plane, or for slope correction or for calculating the slope, would you also recommend a standing scanogram in the lateral plane for all patients as a routine?
Yeah, not for all patients. That's a very good remark. However, the best is, of course, especially in patients where I'm going to talk about in my next presentation, where you have a slope issue, you have a deformity in the sagittal plane, you would like, ideally, have a standing lateral view of the whole leg. In my facilities in Abu Dhabi, we have that possibility. But for example, in the Netherlands clinic, it's very difficult to have such a kind of visualization. So we do it in another way. But it's mandatory, and you're exactly right, to have the right x-rays. So perfectly would be lateral views also for the whole leg. But for me, if it's a straightforward frontal plane deformity, and I have no indication that anything else is happening in the sagittal plane, I'm not going to make that standing sagittal plane X-ray.
All right, thank you.
Yeah, Parag, any questions on the chat?
There's one question come on the chat. So, when we are doing a high tibial osteotomy for osteoarthritis, which is a very common condition in India, do we always have to do the planning what you have shown, or we can just go by intraoperative? We do the cautery cord test, where we can just put it and then do arbitrary planning. So is it absolutely essential to plan in a high tibial osteotomy for osteoarthritis the way you have shown?
Well, the advanced planning method I'm not doing in every other patient, but I do not like to do osteotomies without preoperative planning. I think it's mandatory to do a preoperative planning. A cautery cord is not the same in accuracy as a long leg rod, which is a better way. But to be honest, the long leg rod is not necessary if you have made a proper preoperative planning. So do not make the mistake that you go into the OR with only a cautery rod for your osteotomy and your correction, because things can go terribly wrong if you haven't found the deformity where in your deformity analysis, and you can do an HTO then where you could have recognized the deformity in the femur, and you should have done a femur correction. So I would always recommend to do a preoperative planning.
Absolutely. Thanks.
Yeah, Ronald, one more question here. Do you do any special tests to look at bone density before you plan the osteotomy, if in doubt?
If I have a patient that has a metabolic disease where I can expect bone density problems, I would do. And in elderly patients, I sometimes do, but it's very rare to do that. I know, and I've witnessed also in Pune during the live surgeries, that bone density is an issue in India. And for that matter, I think if I would work more in India, I would concentrate also more on the bone densities and also for fixation. Okay. But in my country, to be honest, it's not a big deal.
Yeah. Two more questions, Ronald, here is that in the case that you showed where you did a multi-level osteotomy in the upper end of the tibia and at the distal tibia, were you bothered about ankle instability, and why did you not stabilize the fibula? So that's a surgeon from Thailand who's asking that question.
These are very, very good questions. The fibula doesn't need stabilization if you have an angle stable implant on the tibia. We do fibula osteotomies in lower leg corrections very often, and it's not necessary. However, and that's a detail I will present in the rotational osteotomy talk later on. Okay. I'd like to do my osteotomy at a little bit higher level in the fibula than it's performed in the tibia. There's no issue on instability of the ankle in these patients, so don't worry. There are 6 weeks on crutches, partial weight bearing, up to 25 to maximum 50% with 2 crutches. And sometimes I put them in a walker. So there's no stability issue there.
Okay, one question from Dr. Maheshwari from Delhi is that when you're doing a varus, like the one that you showed the patient from Abu Dhabi, I mean, what is the cutoff that you will accept? You know, how far would you take the MPTA from its normal value of 87? Would you go to 90, 92, or, you know, there's a cutoff limit beyond which you will go to the femur and not do everything in the tibia?
Yeah, well, these are the right questions, because I can understand from that these are experienced surgeons. My cutoff value is 95, MPTA 95. So I do a preoperative planning. Of course, I recognize sometimes that there is also a small deformity in the femur. If after my planning, which is, for example, aimed to unload the medial compartment, and the planning gives me a number of MPTA which is above 95, I will not accept that. I will have to include a femoral osteotomy. So if you're dealing with big varus, do not be reluctant to do a femoral osteotomy. If you end up with an oblique joint line, it is way worse for your patient. These shearing forces are devastating for a joint. So you have to include a femoral osteotomy. And you can also do it in 2 surgeries. If you explain it to the patient and you're afraid to do a double osteotomy in 1 surgery, you can also do first the femoral osteotomy and then the tibial osteotomy. So stage it like that. But I would not accept an MPTA which is more than 95 for a varus to neutral or varus to valgus correction.
Okay, perfect. So Ronald, we have, I think, close to 4,500 surgeons who are logged in right now. And okay. I think I want to take that opportunity to sort of show them why I call you the magician. So friends, this is just a small video on Ronald, what he is. And he's the person who's taught most of us how to evaluate patients. Take, for example, this lady here, who had been given up on everyone, and she was completely fed up with her life. She couldn't walk. She had a very nasty KD5 with involvement of her artery and her nerve with a foot drop. She had a completely lax knee. She had a subluxed tibia, and she had multiple surgeries, and her husband was completely frustrated. So was the whole family, and she had absolutely no inclination of taking it ahead. This was what we were faced with. One can see that the whole tibia was completely subluxed, and this probably was one of those patients in whom we all felt that, at the young age of maybe 32, it would be time for us to do a hinge. That's when we called the magician in, and he did a detailed examination of this lady. For all of those who were with us, he went through
Yeah, Sachin, I think you give the commentary. We can't hear him.
Sachin, sir, you have to continue the commentary.
You continue. We cannot hear him.
So Ronald went ahead. He sort of explained to us all the different types of how he evaluated this deformity. He explained to us that there's a negative slope. And then for this negative slope, what are the things we should be doing to help her out? With this sort of understanding of what was there for this patient, he was quite sure that once you correct the slope, then probably the varus will disappear. To be very sure, none of us believed what he said was true, because it was completely difficult to understand that by correcting the slope, how will this whole knee, which was in complete varus, become straight? But so far we'd heard, stories of his magic, and I think it was really important that we see the magic. And though when we showed him all the CT scans, understood all his explanation, it looked like it was not going to be something that was going to be palatable for all of us. So then came the D-Day, where in front of over 1,000 people, he went in completely live. He went in live. He showed us how to expose from the midline, how to use what is called as a biological plate, which is nothing more but a tibial tubercle osteotomy. And look at the way and the finesse that he does the tibial tubercle osteotomy, and he takes out a perfect tongue of the tibial tubercle, which goes for more than 6 to 8 centimeters, pushes guide wires in from the front to the back to the insertion point of the PCL, explaining each step in detail. It takes guts to do such difficult cases, which have been operated before a couple of times, live in front of everyone, but perfect precision, perfect respect to soft tissues, excellent understanding and demonstration of all the biomechanics, getting the correct steps to be absolutely visualized by us, showing us that when we do open and correct the slope, how the collateral ligaments to tension them up, planning everything to perfect precision by inserting bone grafts to fix it, and showing us what it takes to be an absolute magician. So this was what he delivered to us in that live surgery then. He also took meticulous care to close the tibial tubercle, to fix the osteotomy, and I think what happened from then on was nothing short but pure magic. He went on to show that, she's going to heal down, she's going to stabilize well, and what a master of perfection he was, truly deserved a standing applause from everyone. And this was what she was. Couple of months down the track, her whole limb was looking completely straight, and she'd come in to have some residual laxity corrected on her lateral side, because you can see that she's having some bit of thrust there. And then I took her up to do a removal of her implants, and also at the same time did a posterolateral corner reconstruction for her. This was her healed X-ray then. And this is what she shared today. She's walking about in her house. This is today during the lockdown period. She's doing all her daily activities. She's got a foot drop needs to be sorted out. But besides that, I think she's completely, absolutely, perfectly normal. She's happy, the family is happy, and no wonder we call him the magician. Ronald, that's what you are. Thank you so very much. And we'd love to have you give your second talk now, if you may so please, on how do we manage ligament laxities with slope correction osteotomies. Thank you, Ronald.
Well, first I have to get back to earth again after your very, very nice words. I'm not a magician, but I think sometimes we do surgeries which are somewhat abnormal, and I can understand that that's looks like magic for the audience. But thank you for all the credits you gave. I hope I'm now on the screen again for a continuation on this topic.
Yes,
Can
please.
you see the presentation?
Yes, absolutely perfect.
Okay. To add to this case, the difficulty was also the drop foot in such a case, which makes that it's very hard for the patient to walk with the combination of deformities and the drop foot. And as such, I think when you correct the bone as good as that's possible, the bone always wins. So if the bone is corrected, you have a stable basis to continue from there. Very nice that you show me the now locked in walking video. This is a very nice lady, a very nice family, and I hope you can say hi to them, and that I'm very happy to see them again, or even on video. Now let's go to slope corrections for ligament laxity. There is a different definition, different nomenclature on this topic. So we're looking now at the side view of the leg. This is out of Paley's Principles book again. You have different angles there, which we are not very familiar with, especially not on the femur. However, very important is to realize the method of slope measurement. The method of slope measurement takes into account that from anterior to posterior, you divide the distance in 5 equal distances. At 1/5 from the anterior part, you make a dot on the X-ray at 1/5 of the anterior part. And then the second dot is at the middle of the tibial plafond distally in the pure sagittal plane. From there, you draw a line proximal to distal, and the line of the slope of the proximal tibia angles to that. And that angulation from that line through the shaft, the mechanical axis, and the line which is parallel to the tibial plateau on the sagittal view is the posterior proximal tibial angle, and norm value is 81. You remember that case in the surgical planning talk? She had 51, norm is 81. From that, you can have a procurvatum if you have a femoral or a tibial deformity, which means that you have a flexion deformity. And if you have an extension deformity, it may be due to a bone abnormality which causes recurvatum of the knee. Then the posterior proximal tibia angle is larger than 84. So it's larger than the spread of the angles which are normal, considered normal. So for example, if you have a slope which is 90 degrees, so then you have by definition a recurvatum in that knee, considering that the soft tissues in the back are not scarred. So from that measurement, you can find out where the deformities are. So I recommend to you, go and find your reference values like I show you here in the publications on the sagittal plane deformities. Now look at this leg. And I first showed this picture. I will never forget that in a talk on ESCA 2010. This was a talk on failed posterior cruciate ligament reconstructions. And I was just the odd duck at the end of the session. And I said, well, we all know this is a posterior tibial sag, and they're all ligament surgeons there in the room. But I said, this posterior cruciate ligament is totally normal. And then the room went quiet because I showed them this picture. This is a posterior tibial sag because of a recurvatum after a post-traumatic early closure of a tibial tuberosity growth plate. If that growth plate of the tibial tuberosity closes premature, you will have a normal growth in the back of the knee, and you will have a severely negative slope, and resulting of that is a posterior tibial sag. So sometimes what you see is not what you get. And this is a different way of thinking, to bones instead of ligaments. And if you can keep up with that, follow me through the presentation and always think of the bone. The bone wins from the ligaments. So here we are. This is a very important publication by the group of Philip Lobenhofer, then with Jens Agnes-Kirchner together. They performed a very nice investigation, changing the slope in a mechanical device after they had cut the PCL. So they were looking at what is the influence of a flexion, open wedge flexion high tibial osteotomy in reducing the tibia, which is posteriorly sagged because of a PCL insufficiency. And they gradually increased the slope and looked at the position of the tibia relative to the femur. Now look at this graph. On the left side, it shows PCL cut. Where's the tibia? The tibia is posterior with a 0 degrees of slope. If you only, it's a normal slope as a reference. If you only increase 5 degrees in slope, immediately the posterior sag is reduced and the tibia moves forward with only a 5-degree slope change. That means that you can replace the function of the PCL by only a 5 degrees of slope change. And of course, if you need more, the effect is stronger. And it was clearly shown by this group that a posterior subluxation of the tibia can be reduced by an increase of the slope. That was what I did in this Indian patient in the live surgery. I reduced that posterior subluxated tibia with a negative slope to a normal position with a fairly normal slope by an open wedge high tibial osteotomy. This is from Imhoff, the group of Imhoff, and they made some drawings to show that effect. If you have a negative slope, the femur wants to move forward on the tibia. If you have a increased slope, the tibia wants to move forward instead of the femur, and the femur moves backwards. Now we all know the situation which is drawn up on number C on the right side. If you have a high slope, your ACL is in danger, very much in danger. You have a much higher chance of rupturing your ACL. Now think of a high slope like that on the right-sided figure in the bone, and then that you want to do an ACL reconstruction. What is the chance that this ACL reconstruction will survive in a too high slope? Because the forces during stance and walking are against your ACL, are against your ACL graft. The other situation is in A, it's bad for your PCL graft if you have a negative slope. This is courtesy of Professor Philip Lobenhover, a good friend of mine, excellent osteotomy surgeon, who gave me these slides. And I've used it a couple of times since then to illustrate the phenomenon that plays with tibial slope changes. The tibial slope in this patient was changed after a high tibial osteotomy. And here I show the importance of good x-rays. So this is the contralateral normal side. This is, well, not only one ACL surgery, ACL reconstruction. This patient had 3 failed ACL reconstructions. And in one time, as I was told by Philip, she didn't even succeed to her 6 months rehabilitation after the previous ACL reconstruction. Well, that's a disaster. What was the case? Look at this. The normal knee on the left side had a normal slope, even a low slope. The right side, you see the subluxation happening there. The femur subluxes posteriorly, the tibia subluxes anteriorly because of that very high slope, which was caused by a high tibial osteotomy performed the wrong way. So they increased the slope of the proximal tibia by the high tibial osteotomy. That was the cause that all these ACL reconstructions failed. So, very important, recognize the shape of the bone as a cause of your ACL reconstruction failure. This has been recognized. This is a systematic review of clinical evidence, which was published in 2017. The impact of osseous malalignment and realignment procedures in knee ligament surgery. Please read that paper. Very good group of authors of different institutions did a systematic review and found that, to say it more easily, the bone always wins. Your reconstruction fails if you do not look at the bone. What do I use to do these kind of surgeries? Well, you have seen some of the tools already in the live surgery. This is out of my armamentorium. I need some K-wires, I need calibrated chisels, and that's about it. And on the far right side, I cannot see, but the spreaders are important too here. And then, of course, the calibrated saw blades. Some of the other tools you do not recognize, probably you will see in the later presentations. But these are essentially the calibrated chisels, K-wires, that's what I use. If you look at slope-changing osteotomies, you have to realize that in your surgical technique, you have to deal with the tuberosity. Why is that important? Well, it's a big difference if you make your osteotomy and your correction distal to the tuberosity, where the bone heals not so easily, where you need all kind of plating because of large forces acting out there. If you are a plate surgeon. If you do like Elizarov kind of technique, X-fix technique, this is very often used. And they do excellent surgeries like that at this level. But this is not my preferred level of performing slope corrections. If you do slope corrections proximal to the tibial tuberosity, what you see is that with an opening wedge, but also in a closing wedge, you will change the height of the patella. And there's a warning here, because there are all kinds of publications coming out right now, specifically in the field of the ligament surgery journals, where wedges are taken out proximal of the tuberosity. So no touch tuberosity technique. And you have to realize if you take out a wedge, you will heighten the patella. It's only logical. And if you open that bone proximal to the tuberosity and you put in a wedge, you will end up with a low patella, a patella baja. So think about the patella position if you do sagittal plane corrections. The preferred method for me is to do a tibial tubercle osteotomy. And that means that you do a total tuberosity osteotomy, you reflect the tuberosity upwards, you mark where the tuberosity came from, in the proximal part, and that's here, the proximal part, you mark it on the bone, so you can always find back where it was. And of course, then you have a gap here. But if you make a shallow osteotomy, that doesn't matter. You protect that leg anyways. This is an opening wedge. It's the same for me in closing wedge. I do not want to create a new pathology, as in deformity, when I do a sagittal plane correction. I don't want to mess with the extensor apparatus other than replacing the tuberosity back at the exact place where it came from, at the proximal part of that. And only then I can make sure that I'm not giving the patient a new deformity or a new pathology. So I'm not in favor of some of the publications, which are quite recent, on extension osteotomies, slope correction to benefit ACL reconstructions. And these slope corrections are above the tuberosity. That's a personal opinion, but it is, I have a population who need large corrections. Abu Dhabi population has very high slopes, and these corrections you cannot do above the tuberosity without creating a patella height problem. So what are we doing? This is what you saw in the video. This is the so-called biological plating technique. We make an oblique cut ending at the hinge point posterior, which is the PCL attachment. That's your reference point. So you aim your K-wires there, then you've taken off the tuberosity, reflected it upwards, you open up the bone, and then you do the so-called biological plating technique. This has been described also by the group of Lobenhofer, but also by Bonnet and other authors before. Biological plating is a very nice technique, and the whole rationale is, where do you want optimally positioned your plate? Where the plate position is actually the tuberosity position. So you use the tuberosity as a plate, hence the name biological plating. You fix it with screws. You can have a screw proximal. Most of the times I only do screws distally, and then these days I put a staple to get a hold of the graft and the bone on the medial and the lateral side. That's my normal technique. And this is an extension osteotomy. This is a high sloped patient. This is a revision ACL situation. And the slope is reduced by anterior closing wedge with a total tuberosity osteotomy. Many cases like that with much bigger corrections we do in the Abu Dhabi population, often combined with the famous Dr. Brown doing the revision ACL surgeries in these patients. And I'm only adding with an extension osteotomy. And that's the work for these patients. Now, there are other ligaments on the knee. So this is not slope correction, but just to show you how you can play around with ligament tension. What do you do with a chronic MCL laxity? As I know that many of the patients in India have varus legs, if you have a chronic MCL laxity and you cannot do anything with the ligament itself, do a small opening wedge osteotomy. Normally in opening wedge osteotomy, you have to release, like is shown here, you have to release that medial collateral ligament. Well, if you do not release it, you will tense it. So by a small opening wedge HTO, you can retension a chronically insufficient MCL. What about the lateral collateral ligament? This is from a publication I wrote in one of the books together with Bob Taichi. He said, well, what do I do with these failed high tibial osteotomy with these very high riding fibulas? They all have a lateral laxity. So if you think of tensing the lateral collateral ligament, think of a shortening osteotomy. Be careful in this area, but you can do that, a shortening osteotomy. That will easily tense that lateral collateral ligament. It's just a matter of thinking of bone instead of ligaments. So the ligaments are intact, but they're not working. You only have to tense them, and you can retense them with osteotomies. Some literature, open wedge high tibial osteotomy for posterolateral corner insufficiency. Look at the group of Laprade who published on that. 38%, almost 40% didn't need any second stage ligamentous reconstruction after such an osteotomy. And this is also an example about timing of osteotomy in ligament insufficiencies. This is a case of 15 previous surgeries in a multi-ligament injured patient. And she has been having surgery from all the high-level experts around the world. Well, this tibia and femur, for me, looks like cheese. We have a lot of cheese in the Netherlands, and we have a lot of holes in cheese, and we have a lot of tunnels and holes in that kind of bone. So if you want to go with an osteotomy, and she hasn't had an osteotomy, where's the osteotomy? In a multi-ligament failure after failure after failure case, which now has developed into a varus with medial OA. Maybe at some point a osteotomy would have been beneficial to help the ligament reconstructions. It's just a question. It's been proven that osteotomies need to go first or go into combination with ligament reconstructions if ligaments fail. So consider to do osteotomies first before you do your ligament reconstruction, or combine, because, and I stated again and again, the bone wins. Your ligament will fail. If you still have a high slope, your ACL reconstruction will fail. So please think about that. Don't forget the sagittal plane. The tibial slope has a direct influence on sagittal plane stability. Sometimes you do not need an ACL reconstruction anymore after you have corrected the slope. Osteotomies can reduce or increase the stresses on knee ligaments, and pay attention to the technical details. The patella height is very important. The tuberosity position is equally important. So think about that in planning your sagittal plane corrections. That's the end of this presentation.
Thank you, Ronald. That was simply amazing and completely breathtaking. We have a couple of questions coming in. So if there are any questions from the panel, they can shoot the questions through. Otherwise, we have a couple of questions coming in. The first question is that when you do a tibial tubercle osteotomy, like in a biological plating, can we start flexing the knee post-surgery, or do we have to splint them in full extension till the tibial tubercle heals?
Very good question. I'd like to, you've seen me using 3 screws. On the poster, the announcement, there was a bigger screw with a washer used. If your fixation is stable enough, functional rehabilitation is possible, but not against resistance. So flexion of the knees is allowed in my patients. I always splint them for 6 weeks in a removable splint while standing and walking. So they have to have that to have a good bone healing.
Okay. Anshu, you have a question? Can you come through? Yeah.
Yeah. So my question is, when you're doing a high tibial osteotomy for, let us say, an ACL laxity, which is having a high slope and a varus knee, so you decide to increase the slope at the same time when you're doing the high tibial osteotomy. Is there any method wherein you can determine how much slope are you changing by playing around with the trapezoidal gap, and reverse for a PCL, of course?
Well, there are a lot of there are a lot of questions in this question, Dr. Ansu, but you've seen us working in Abu Dhabi, Dr. Brown and myself, on these cases. First of all, where is the biggest deformity? So if the biggest deformity is a very high slope, you have to do a sagittal plane correction. If the biggest deformity is varus, you want to correct the varus. And if there is also like a slope abnormality like 5 to 6 degrees, it's possible, and it has been described in papers by Dr. Laprade, and I've also published a paper on that with Dr. Amendola, that you break the hinge or you make the hinge weak in an open wedge osteotomy, and at the same time correct the varus, and by putting your spreader into the back, you correct some of the slope. However, more than like 6 degrees of slope correction is not possible in such a way. If you want to correct more, probably go in 2 stages if you have to correct varus as well as sagittal plane correction slope.
Okay, so which one would you do first? Would you correct the sagittal first or the coronal first?
Normally I would do the sagittal first, and then it's easy to take the material out, do your open wedge high tibial osteotomy, for example, to unload the medial part. That can be easily combined with a ACL reconstruction or any other kind of reconstruction. We do combine, and you have seen that, we do combine slope corrections with ligament reconstructions, but the rehabilitation is kind of hampered by the splint. So the rehabilitation after a combined varus to valgus high tibial osteotomy is very aggressive and can be full weight bearing almost from the start, whereas you are on crutches for 6 weeks in a splint in that other reconstruction. So if we do it staged, we do the sagittal plane first.
Ronald, so let's take Anshu's question one step ahead. So we've done the coronal plane planning. This is a ACL deficient knee in which you want, if the slope is high, we want to decrease the slope, and we want to sort of correct the coronal plane as well. Now, on my coronal plane planning, I measure that the gap I want to open is about 9 millimeters on the medial side. So when I'm translating that intraoperatively, should the 9 millimeters be the posterior opening or the anterior opening?
Definitely in your patient, when he has an ACL, it should be the posterior opening. It is always the posterior opening when you do your planning. So the planning is on posterior opening. In such a case, you can also use, with a pointed reduction clamp, you can also put the pointed reduction clamp on the anterior part of the wedge. So you can reduce the slope by putting it on the anterior part and putting the spreader open to 9 millimeter. That's the trick.
Perfect. Yes. Yes. Parag, you have a question?
Yeah, I have a question. There's a question which has come in. In the case of a primary ACL reconstruction, if you notice that the slope is increased and also the slope is similar on the opposite side, which is an intact ACL, would you consider a slope modification in doing a primary ACL reconstruction?
That's a very good question. We do it, not in each and every case, and only in high sloped patients. These, you have to realize that as good as an ACL surgeon you may be, it's not the ACL. You put in a graft, and the graft can never be 100% the same as your ACL. So that graft takes much more forces in a high sloped patient than in a normal slope patient. So to help the graft, which is let's face it, which is not an ideal solution, I would recommend, if the slope is high, we're not talking about like 3 degrees off or 4 degrees off. We're talking about like 10 degrees off. Then your reconstruction is in danger. So then you should consider combined slope correction with ACL reconstruction or 2-stage.
Okay, Nilesh, you have a question? And then we have a couple of more before we move on to the next talk. Nilesh, you need to unmute yourself, please.
Yeah, my apologies. So in a similar setting where you're talking about a middle-aged active individual with an ACL deficient knee, what is the criteria to determine that he will require a slope correction and an ACL? Meaning that can we just do the slope correction and stop at that? Or what will make me sure that, no, I need to go ahead and do an ACL for him as well?
First of all, Milesh, thank you for the question. I'm middle-aged too. So we're talking about healthy, active people here.
Right.
And it is actually the same things to think over, where you make your decision on, will I do a combined open wedge high tibial osteotomy with an ACL reconstruction, or will I just go for open wedge HTO? The age for me is not a limiting factor here. It is, of course, in some of these patients, you want to go two-stage because you expect, for example, in the chronic PCL deficient patients, you expect that only doing the slope is enough. And look at the paper of Agnes Kirchner and Lobenhofer.
Right.
Often it is enough. It is my experience. It is enough. Then in the ACL deficient patient, yes, if there's a gross instability, like pivot shift 3, I do not expect my slope correction to be enough in such a patient. However, if the laxity is not that big, probably it's enough. So then you can go for a one stage. So
Right.
you tailor it to the patient.
Right. And just a sub question on that. Is it mandatory to use a plate with angular stability, or spacer plates are still in vogue? They are not yet out of vogue.
To be honest, whatever plate you use, you feel comfortable with, whether it's angle stable or not. Yes, the angle stable plates are kind of better and stronger as a construct. However, if you tailor your rehab accordingly, you can use any other plate.
Okay.
Because any other plate, it will take a longer rehabilitation. It will take adaptations in your rehab, and that you have to know as a surgeon. You have to know how strong your plate is, and you have to know what your rehabilitation protocol is according to that plate. The best are the angle stable plates, and they're good ones, but if you do not have possession of that, you can do with the other plates too.
Right, thank you.
Okay, Ronald, couple of quick questions here. The first question is that what is the correlation between the opening of, if you're doing a flexion or an extension, anterior opening or a closing wedge osteotomy, how much millimeters of opening translates to how many degrees of correction?
That's the non-answered question. If you are a close reader of the literature, you will find that in publications of very well-respected institutes, sometimes in between two publications of the same institute, these numbers, these correlations differ. And they differ, for example, between the institutes. So how can I help you there? Well, first of all, we're going to publish a paper on that, I hope, this year. But that's not a good answer. I'm working with calibrated X-rays, and that can help you. If you have knowledge of how many millimeters you are working with in your X-ray, then you can always transfer the aimed angle of correction to the aimed millimeters of correction. That also works in the sagittal plane. But a rule of thumb for sagittal plane corrections, read the literature and you will not find it. There will be papers coming out there on surgical technique, but they're not there yet. And it's a very good question, but I cannot give you the answer. I do it with calibrated X-ray planning.
Okay, Dr. Dinshaw has a question. His question is that when you're correcting a severe valgus and doing a corrective osteotomy, do you ever sort of consider doing a prophylactic peroneal nerve release as a part of the surgical procedure?
Well, that's a very good question. That's coming back to the surgical planning lecture, actually, because if you have a post-traumatic situation, especially post-traumatic, but also some of these congenital deformities, you can expect the nerve to be short or captured in scarred tissue. If that's the situation, you have to do a release, because the stretching alone will give a dysfunctional nerve. You have to warn these patients before the surgery. Tell them, as part of the surgery, as part of the correction, I have to accept that there is a risk of stretching. You have to go to the nerve, unwind it, or release it from scar tissue, and then do your correction. In large corrections, that's an issue. If there's never been any knife or never been a trauma, no scarring in the tissue and you are only correcting in one plane, normally there is not an issue, even in bigger corrections. But if you're scarring, if you have certain congenital deformities, you can get into trouble.
Okay. Can we use an MRI scan for calculation of posterior tibial slope? Will it be more accurate than an X-ray? And if so, on the MR scan, should we look at the medial or the lateral tibial condyle?
These are very, very good questions. I have to tell you that I'm not working with MRI scans, even though there are excellent papers out there that say the slope on X-rays is not the same as the slope the cartilage makes. I use sometimes the cartilage slope, cartilaginous slope on an MRI scan. These are specifically in syndromes where you can expect that the cartilage doesn't reflect the same line as in bone deformities. There I use MRI scans. The medial and the lateral side of the knee slope are different. We know that. Even if you zoom in on your X-rays, you can find that. I tend to use the lateral tibial plateau slope as the slope I correct on. I make my plannings on, the lateral tibial plateau slope. So if I use an MRI scan for slope correction calculation, I also use that one, that plateau on an MRI scan.
Okay, another question is that in an ACL deficient knee, because of decreasing the slope, are we going to increase the chance of hyperextension of the knee, and would that be counterproductive?
Very good observation, very good question. Yes, some of these patients need big slope corrections. At that stage, you will have a residual hyperextension. What do I mean with residual hyperextension? If you do slope corrections, there will always be a hematoma around the area of your correction. And I realized while starting these kind of surgeries, of course, that you create a hyperextension. You can even find it already in your surgery. And I was worried about it. But case after case, I found out that if you go to correction to a normal slope situation from a high slope, often the hematoma you create prevents that a severe hyperextension will be the result of your surgery. If in the surgery where you have to make a large correction, or if there is a pre-existent hyperextension of the knee, you have to do a soft tissue procedure. And what we do in Abu Dhabi practice, Dr. Brown does a posteromedial advancement, and that works. If you splint the patient afterwards, which is the normal procedure, the splinting, you will have scarring down after a retension posteromedial capsule. And these patients do not have hyperextension issues after slope corrections. Normally, slope corrections up to normal, slope corrections like 10 degrees max will not produce a hyperextension problem for a patient in the presence of the hematoma and the healing with hematoma scarring in extending osteotomies in ACL patients.
Okay, that's a very good explanation of the same. Two last questions before I allow you to move on to the next presentation. Sorry for that. When you're doing a sagittal plane correction, do you require a fibular osteotomy? If so, when and where?
I've shown the different types of osteotomies. If you do a correction under the tuberosity level, you need a fibular osteotomy. If you do it at the tuberosity level or above the tuberosity level in small corrections, then you do not need a fibular osteotomy. So that's because the hinge point is then at a level above the fibula, tibiofibular, proximal tibiofibular joint. So that's why.
Have you ever faced a case where the tibial tubercle osteotomy, the biological plate, has gone into non-union? If so, how did you address that?
Well, that's a very difficult situation. I have to confess that. Yes, if you do enough, you always face complications, and I've made many complications. I have to make sure that you understand that. That is part of the deal. And you don't want these complications, but you will have to face and to address them. I have these cases. These are difficult situations because you have to go back. You have to bone graft them. You have to sometimes remove your current fixation and replace it by other fixations, which may be difficult. If your tuberosity is too shallow, you have too thin a tuberosity, then if you go into a non-union situation, you are in danger. So make your tuberosity cut proximally big enough, deep enough, and you can also use what we call V-shaped osteotomies of the tuberosity to have a higher amount of spongeous bone contact. So these are the tricks you can do for a tuberosity osteotomy.
Okay, last question before you move on to the next talk. Suppose there's a patient who has a ACL, PCL deficient knee, which is neglected, and we need a slope correction. How would you address the slope? Would you decrease the slope for the ACL, or will you increase the slope for the PCL?
Well, that's a question from a ligament surgeon. Now, I'm a bone surgeon, and look at my perspective. I will do nothing if the bone is normal.
Okay.
And if the bone is abnormal, I will create the best opportunity for the patient if I correct the slope to a normal, and then the ligament surgeons, which I greatly respect, can do their work.
Okay, thank you, Ronald. And I think we'll move on to the next part of your presentation, where you discuss with us how do you tackle rotational problems and correct them with osteotomies. Thank you so much, Ronald.
Okay, this is a favorite topic. So if I go over time, you have to stop me, because this is the most interesting topic, I think, in osteotomies, apart from the intra-articular. So 2 more presentations to go. Rotational osteotomies is so interesting to me, and I'm going to put it on full screen. So you can see it now, full screen?
Absolutely, absolutely.
Okay. Rotational osteotomies is a favor of mine because it has its own world of patients. And these patients are having complaints which are often not well understood. So first, the terminology for rotational deformities. Version is a normal rotation of a bone. Torsion is an abnormal rotation in a bone. And even in the literature, mistakes are made. So rotation of a bone, which is abnormal, is called torsion. The terminology also is kneeing in, kneeing out, toeing in, toeing out. That's looking at gait of patients. And coxa ante and retrotorta are positions of a hip in a femoral rotational deformity. And rotational malalignment after fractures is well known. Exotorsion of the tibia is an abnormal torsion where torsion in the version in the external way, the foot pointing out, is normal in most tibia. However, there are differences between the races. A Japanese tibia has much less external version than a Caucasian population and Indian population tibia. And a torsion malalignment syndrome or misral malalignment syndrome patient has a femoral as well as a tibial deformity in the rotational plane. For me as a resident, it was very difficult to understand why a anteverted hip, so a rotational deformity in the femur, causes a kneeing in and a toeing in, until I found this drawing. Look at the drawing. You see on the table laying a patient with a much anteverted hip. And at that position, the knee is pointing forward and the foot may point forward. So there is no tibial deformity. However, when the patient stands from the table and walks, the hip wants to position the hip joint and the femur in the hip joint in 10 to 20 degrees of anteversion position. That's just what the hip joint wants. And I realized that sometimes as a result of a deformity, the capsule is stretched to allow more abnormal position of the hip. But normally the hip wants to function like this. And as a result of that, the anteverted hip causes a kneeing in and a toeing in. That you should realize. That's why kneeing in exists in the presence of a femoral deformity. Often the complaints of patients go unnoticed. In the hip, some not very specific groin pain can exist. There are patients who have instability problems of the hip. Persistent trochanteric bursitis may be caused by a femoral rotational deformity. Impingement, early osteoarthritis of the hip in families, these are the families who have a retrotorsion of the femur. So the hip is pointing backwards. At very young age, in the 20s, they develop osteoarthritis of the hip. Most often, patients with rotational deformities, whether it's femur, tibia, or combined, have patellofemoral problems. Because the patellofemoral joint is a very simple joint as in function. The patella just wants to move in one plane and wants to move in that trochlea. And if that trochlea is rotated internally or externally, the patella doesn't know what to do anymore. And overpressures and all kind of stresses on the structures around the patella are occurring. Even severe patellar instability may occur. Gait abnormalities at the ankle joints are present, and fatigue in muscles around the ankle, as well as osteoarthritis because of a rotational deformity in the lower leg. This is an excellent paper of Bob Chaichi, who in the book of Frank Noyes on knee disorders in 2010 included some drawings. Look at the right side, all the vectors, the arrows that are showing what happens in a rotational deformity. An inward twisting of the femur causes a lateral factor at the patella. And also a rotational deformity in the tibia causes a lateral tracking of the patella and patellar instability because of that tibial deformity. So if you think of patellar tracking and how difficult that is for a knee, when there is a bone abnormality in the femur or the tibia, or often combined, you have a good understanding why, and look at the left side then, from a balanced compression, something totally different is present when you look at cartilage forces. There's a huge compression on the cartilage, on the outside, the lateral facet of the patella, and the trochlea are outside, when you have an inward twisting of the knee in the femur. And likewise, if you have an external torsion deformity with a lateral position of the tuberosity, that patella wants to move lateral, wants to move out. A lot of tension increase on the medial capsule. And when you understand that, you can understand that patients with rotational deformities have patellofemoral problems. Now, this is how I examine these patients. And this takes only like 15 seconds, so do it. The next 20 patients with patellofemoral problems, please put them supine, examine, like this is Staheley's rotational profile examination, examine the rotations in the hip. Is that asymmetrical? Is there an indication of a femoral deformity? Or if you look at the flexed knee foot position, is that an external torsion of the foot relative to the knee? And look at the gait. Is there kneeing in? Is there toeing out? Or one or the other? And some of these patients can produce extreme flexibility. I'm not doing this on a daily basis, I can tell you that. But this girl can produce something like this. And when I examine her, you can easily find what's happening here. She has enormous asymmetric rotation, internal versus external rotation. So she's far off, lying like this, and she cannot go over, she cannot even reach the 0, and she should normally also externally rotate up to 45 degrees here, or internally rotate. And that's on both legs. Nice banana socks, she has no abnormality in the tibia. So this is a clear, severe anti-torsion in the femur and a normal tibia. And she can produce a gymnastic exercise almost like that. And she is presenting with patellofemoral complaints, not because of she can do this, but because she has these forces on the patella. And that's why these patients come at young age already for these corrections. This is my daughter. And what a father I am that I put her to a photographer and want him to do the pictures on her. And this is exactly the same as in that patient. She could do a lot of rotation and she couldn't come over to the 0 point at the other direction. And her feet were normal. So this is my daughter Iris at 2.5 years of age. Now, I examined her like every other year to see what growth would do. Because I know that 90% of untorted femurs correct spontaneously before the age of 9 years old in young females. And this is her later on. When I asked her, so she's now 12, when I asked her to do the same, she couldn't do it anymore. She now could do like this. This is not very elegant for a young lady, but okay, she could do. And this is her rotational profile, which is fully normal. And this may be a little bit high, but that's not abnormal. So as a dad, I was very happy. Growth helped me here. So rotational deformities can correct spontaneously up to 9 to 10 years old in females and up to 12, sometimes even later in males. But then you cannot expect a spontaneous correction anymore. I've written something on that. This is a publication 2003. It's been repeated in the books we did on osteotomies. And these are the normal values. And this is Caucasian population, but I think in India it will be the same. At birth, anteversion is 40 degrees, 10 years old, 24, adult, 10 to 20 degrees. And you know that when you put in a hip prosthesis, that this is the anteversion you should aim for. Then the tibia version. All children have internal version of the tibia when they are born. The feet point inwards. When they start walking, it looks funny because the feet are inward and they stumble a lot. And then the feet grow outwards. That's normal. At 10 years, 10 degrees, adult life. Well, 10 to 20 already at that age. Another 2 years of external rotation growth in male. And then you end up normally in Caucasian population, 20 to 25 degrees. Out of that, we made a table putting these normal values in, 2 times standard deviation, and then you have your indication for surgery. And I won't go into that too deep. I'm just going to present cases to show you what you can do with rotational osteotomies. But these reference values for when to think about correction, tibial correction, 35 degrees of external version torsion in that abnormal situation, I would consider doing a correction. If we are above 20 to 25 degrees of femoral rotation and kneeing in complaints with patellofemoral, I would consider a femoral rotation. This is X-ray examination. These are, if you do not have access easily of CT scans for rotational profile measurements, the femoral measurements, according to Dunn, can still be used to measure anteversion. Anteversion measurements with Dunn views are still, can be used. However, the standard these days is a CT scan measurement at hip, distal knee, proximal tibia, ankle. And this is how you measure that. And there are different measurement methods, and there are many papers on this topic, which measurement is more accurate. Weidelich's measurement, Weidelich is the author, is considered the reference method for measuring the rotational deformities and make your planning for deformity correction. These are the tools. Out of the gasket, I would like to have these angles from AO, you know them, K-wires, and I have the possession of this ruler, this angular measurement tool, and you will see that in some of the pictures in the cases I'm going to present. So at the rotation level of the femur, you can choose proximal, shaft, distal. Shaft corrections you can do with nails, and that's always an option. However, the better healing bone is at the proximal and specifically at the distal area of the femur. Intra-trochanteric osteotomy or subtrochanteric osteotomy, I've done a lot, but I'm refraining from that these days. I'd like to do the corrections near the knee joint. But this is just an example of such a correction. AO books write about that, and that's with the angle stable plate there at the proximal femur, a very good fixation for such a surgery. This is what I do most often in the femoral corrections. And I go step by step. So this is the supracondylar level, distal femoral level, step by step in this video. This is an incision. You can go mini-invasive too, but I'd like to visualize these perforantous vessels there because they can bleed very hard. So I make a little bit bigger incision there. This is K-wires off, and then you have rotated after you have cut the tibia. This is off-label use of a medial distal femur plate for a lateral fixation. Lateral fixation. After the rotation, lateral fixation. Sometimes I add a staple on the medial side. I test it during the surgery, and then I close that. And at that time, we still used a drain. These days, we use tranexamic acid, and we do not use drains anymore in these patients. But that's, in short steps, a distal femoral rotation osteotomy. Then you have these torsion malalignment syndrome patients. And at that time, I did my rotations with medial plate fixation. And sometimes if you also want to correct valgus in a patient, which may be a frontal plane deformity too, you can do a medial plating there. And this is also a rotation at the tibia level. So this patient not only had an abnormal rotation here in that leg, she could move far more than normal, but she couldn't move over the midline. And then you look at the tibia and the foot position. She also has a femoral and a tibial deformity, so a miserable malalignment. You have to correct both femur as well as tibia. Look at this young lady and how she walks. You've seen her walking already. Again, she was sent in for valgus correction. Now, look at where her knee is going. She has severe kneeing in. And actually, that's what she has. She has a rotational deformity because the frontal plane is normal. She has a very straight, normal leg. So this is the importance of putting the patella forward. And where that foot is pointing at, well, that foot is pointing outwards, gives you a clue on what's happening here. Do your examination. She has normal femoral excursions, maybe a little bit high, but she comes over the midline and she has abnormal tibia. She has an abnormal tibia. So she has a tibial external torsion deformity. That's causing her, when she puts her foot forward, she needs to put that knee in. Otherwise, she walks funny like Charlie Chaplin, and she cannot walk like that. But look at what that tibial deformity in rotation causes in her walking pattern. She was walking on crutches for many years because of that valgus instability produced by a rotational deformity. This was 40 minutes surgery, a rotation osteotomy distal of the tuberosity because her tuberosity position was normal, fixed with an extra staple on the medial side. 3 months after full healing, And this is walking after 3 months. She has a stable walking pattern. She's very happy with that. Kneeing in just a little, but not abnormal for girls like this. No valgus, no instability anymore. And that's just recognizing that this is a rotational deformity. So look for it and you will find it. If you do rotational corrections at the tibia, you have to deal with the tuberosity. You can have 5 types of proximal tibia rotational osteotomies. The first one is above the tuberosity. You have to realize that if you rotate the distal part, you rotate including the tuberosity, which may be what you want, but may also cause a medialization of the tuberosity if you measure TTTG, which is unwanted. I've seen patients after such an osteotomy at this level who came with medial patella pain and medial subluxations of the patella because the tuberosity was rotated with the distal part medial. Patella tracking was influenced. If you do an osteotomy here below the tuberosity, you can rotate without influencing the tuberosity position. If you do it at the level of the tuberosity, which I prefer because of better bone healing, you can choose either to make a proximal tuberosity osteotomy, intentionally rotating and medializing or lateralizing the tuberosity with the distal part, or if you don't want to influence that tuberosity and the patella tracking, you do a distal tuberosity cut and you rotate the distal part and nothing changes with the tuberosity. Some of the deformities, however, have such a deformity where the tuberosity, whatever you do with it, has to be cut fully and repositioned according to normal TTTG measurements. So that's the 5th, that's a total tuberosity osteotomy combined with the rotational osteotomy. If you do a cut above the tuberosity and rotate the distal part, how far would the tuberosity medialize? Well, there you can make a calculation, and that's just pure mathematics. And a rule of thumb in a normal shaped proximal tibia, like in mathematics, the average shaped in size, 20 degrees of internal rotation causes a tuberosity medialization of 7 millimeters, which may be exactly what you want. If you have a TTTG of like 20 and you want to also treat the tuberosity position with your rotational osteotomy, you may want to make a cut above the tuberosity or a combined cut where your tuberosity will medialize when you rotate internally. So you have to plan that before. And you have to realize that the tuberosity is important when you do a lower leg, a tibia correction. This is such a surgery. Proximal incision, anterolateral approach. If you rotate less than 20 degrees, so maximum is 20 degrees, you do not have to worry about stretching of the nerve if there's no scarring there. And you do not have to do anything to the fibula. So a fibula osteotomy is not necessary if you do a proximal rotation up to 20 degrees. So this is the technique step by step, anterolateral approach. You also go over the tuberosity to the medial side and you make an incision medial to the end point of the pes anserinus, which is also medial to the medial collateral ligament. Then you go subperiosteally with a curved respiratorium around the proximal tibia, and you preserve the pes as well as the MCL, because you have to put in a retractor, because you're going to cut that bone as a whole, and we only want to do something with the bone. So you have to protect the medial structures over there. If you are aiming for the perfect level, sometimes your plate can help you with where you want to make your cut for the perfect stable fixation later on. And then you can choose whether or not to do the tuberosity osteotomy first, because here we're going to rotate internally, but also medialize the tuberosity. And here we have K wires in. We do the cut after we have cut the tuberosity, and then we rotate, and this is the rotation tracker measuring the new position of the foot after the rotation, and then we fix. I always fix and then put in a non-suction drain, and I close the fascia, but I do fasciotomies afterwards, because these are surgeries that wind up that anterior compartment and also can cause compartment syndrome because of that. So be careful with that, take your precautions. So that's the tibia rotational osteotomy proximal. What about distal? I do distal the rotational osteotomies of the tibia when we have patients that are having rotational abnormalities of 20+ degrees. So that can be a congenital deformity or an acquired deformity. Like in this man, 35 degrees of external torsion after a malunion fixation with a nail. And we see these patients very often. This is what you see in a rotational profile examination, and you can do a cut distally, distal tibia where the boning is still good. Rotation, I like to do the fibular cut a little bit higher level than the tibia, because then it's more stable as a situation, and I do plate fixation. At that time, this wasn't a specific plate. Now I use angle stable plates for that. So in the end result is shown here, where you have a normal rotation position. At the distal level, you have to cut the fibula. So you have to include that in your correction. And this is out of the book of Paley. I tend to do my fibular osteotomy a little bit lower. That's more of a safe zone when you well protect the nerve. And that goes for external rotation correction as well as internal rotation correction. So what are the results? Patellofemoral problems and tibial external torsion. Very high, good to excellent results. Pain relief as well as no instability of the patella anymore. Several authors. This is my own series, 23 internal rotation HTOs for external torsion deformities, patellofemoral problems, 9 years follow-up. These are Kujala scores, which are patellofemoral scores, and 17 of 18 patients, because some of these patients had both sides done, would have the surgery again. No instabilities, very good results. Anterior knee pain, this is a series of Bob Taichi, 48 cases, 10 years follow-up, femoral corrections, good results also. And this is femoral and tibia, miserable malalignment, very good results. So these are very rewarding kind of surgeries for your patient. And we see that all the time. It's a life-changing surgery for many of my younger adult patients who come with these problems. Now, take-home message. Look at this patient. She came to me after she had 20 ORs for patellofemoral complaints, which she has since 14 years old. And she remembered she had some kind of high tibial osteotomy as the 3rd and the 4th OR. Look at that foot position. Look at the foot position. This is after rotational high tibial osteotomies. This is 1 year after I did the 21st and the 22nd OR, which were derotational osteotomies, putting that foot position back to normal again. And 23rd and last surgery for her, she already was cured from her patellofemoral complaints, was hardware removal. This could have been prevented. All the arthroscopic nettoyages and all these patella stabilization procedures could have been probably be prevented when it was recognized earlier that she has an overcorrection in her rotational osteotomy. This is where you can find it in the books. These are kind of the indications for rotational corrections. Again, above 25 degrees, I would consider femoral correction. Above 35 degrees in Caucasian population, I would consider a tibial correction. And of course, in post-traumatic cases, I would go for symmetry between the lower legs, and then these values can be even less for a correction. Take-home messages: check for rotational deformities in patients specifically with patellofemoral pathology and all these not understood chronic complaints around the hip and the ankle may be caused by rotational deformities. Analyze the deformity and plan your correction carefully. Femoral as well as tibial corrections show good results with hip, knee, and ankle complaints and patellofemoral pathology. Thank you.
Thank you, Ronald. That was really very nice and a complete eye-opener. Are you tired, Ronald? I mean, you're going on for almost 2 hours. That's why I'm...
Well, I'd like to do the last one too, but if there are questions on this topic, I'd like to
yes.
them,
we'd like you to stay back for another hour, but you know, we don't want to torture you per se. Okay.
No.
Questions. The question is that do you check for hyperlaxity in these patients on whom we are looking at doing torsional corrections? One, and if so, how do you tackle that?
Hyperlaxity is a sagittal plane deformity for the knee, and is often, if there's no bone abnormality, to be addressed by muscle balance training. However, hyperlaxity may also cause that there is a large degree of correction in the hip joint for a femoral rotation deformity. And that is why sometimes on clinical examination, you wouldn't think that this is a bone deformity because of the hyperlaxity in rotational direction at the hip. This is not normal though in the bone, and the bone rules, and the patellar tracking is still abnormal even if you can compensate to some degree in your hip during walking. The trochlea will be put in an internal rotation position and the patella wants to go out. So hyperlaxity is not kind of a situation where the patient is excused for an indication for a rotational deformity. Give that patient a chance. That would be my advice.
Okay. The next question is that, you know, when we're doing a dial test in the prone position, will the presence of a ligament injury or ligament laxity also be sort of, you know, counted in the amount of sort of a thigh foot angle measurement that we do? And how do we sort that out as well?
Well, I can give you another question. In how many of your posterolateral insufficient patients do you do a rotational CT scan?
Never actually.
Never actually.
Yeah.
Well, that's the answer I get a lot. We are finding in our clinics patients who have, at final stage, we find that they have a rotational deformity. And then you have your very, very nice ligamentous reconstructions, and still the patient is complaining of laxity and abnormal walking pattern. And then, question mark is what's happening here? In these patients, we find it. So, no, I wouldn't advise to do CT scans in every patient where you have a posterolateral corner injury. But you have to realize that when you do your physical examination for such a patient, and you do your dial test, also just put that foot plantigrade position. And some patients you will find in many of these who have an abnormal external torsion. Then make the CT scan, because your Laprat reconstruction will not hold up for many years in a patient who has an external torsion deformity. You have to do something.
Yeah, I think that's a very valid point, because I have seen that in my clinical practice, definitely. The next question is that, you know, if one is doing a derotation osteotomy for a patellofemoral problem in the femur, how do you decide where do you want to do it? Do you do it proximal, in the mid shaft, or distal?
If it's a post-traumatic case, for example, and the nail is there, and it's you have to take the nail out. Probably I would do it shaft level and rotate and put in a new nail. Although you can get into trouble, you must put in a reamed nail then, because the orientation of the intramedullary space is different. So that would be the shaft. I prefer distal location, distal osteotomies, because of the bone healing. And I've seen all kind of bone healing problems, and it may have to do with my skills, that I'm not a fan of the proximal femoral osteotomy. It's easy to create new deformities there, but if you are a very skilled hip surgeon and are very good with the angled blade plate, you might as well go there. In my practice, I think 95% I do distal femoral corrections.
Yes, Parag?
Yeah, I have two questions. The first question is that in what percentage of cases have you found that if a patient is coming with patellofemoral pain and you cannot identify any cause, and then you do all the investigations, you do the long leg x-rays, the frontal plane, sagittal plane, that have you come across a rotational deformity as a cause for the patellofemoral pain? What's the percentage?
Yeah, that's not a good question to me. Why is that? I have a reference practice. I have a referral practice in any of the countries I work in the Netherlands, Abu Dhabi, London, and sometimes other countries. So I see patients who are selected already. So I do not have a clue, but I challenge every time, if after I give this talk, I challenge the listeners, the participants, to put the patient supine, investigate the rotational profile in the first like 20 chronic patellofemoral patients. Probably you will find one. That's kind of the frequency you can expect. But these chronic cases where your patellofemoral stabilization procedure fails, or that did have many other conservative treatment or operative treatment, go for it. Make your rotational investigation clinically, and you will already have a clue, and then do your rotational scan, but not as a routine.
There are no papers which kind of indicate a number to it.
No, not that I'm familiar of. This is a field in the spectrum of children orthopedics as well as adults, where there's not many papers.
Okay, so one quick question. Do you use navigation to correct your rotational deformities at any point of time? Do you like navigation?
Yeah, well, I've used it. I was in the pre-stages of navigation systems, so they asked me to test these navigation systems, and we again and again found that specifically the hip center accuracy was not as good, and then I overruled the navigation system from my pre-operative planning. That was as well as in frontal, sagittal, as well as in rotational planes. So Bob Taichi has a great practice. One of the high volume surgeons in France does do it with navigation and has good results with it. And they claim to be more accurate, which it's always in your hands. So if you have good hands with navigation, use the navigation. It can be a valuable tool. For me, it's not a valuable tool. Maybe if I would try the newest generation of systems, I would change my mind, but I'm not using it.
Okay. Ronald, dealing with a patient who requires correction of valgus with a distal femoral osteotomy, what would you prefer? Would you prefer a medial closing wedge or a lateral opening wedge? And if you need to derotate at the same time, would your choice remain the same?
Very good question. If I, because the approach would change. I tend to do a medial closing wedge for valgus correction because it's, and biplanar osteotomies. You have been shown these techniques in previous Pune courses, but also by the presentation by Adrian Wilson and Christian Klein. So biplanar medial closing wedge osteotomy for pure valgus correction is the standard for me. If that leg is shorter, I would go for biplanar lateral opening wedge for a pure valgus correction. If I also need to rotate the level of correction, I put a little bit higher, and then I have to make a full cut of the bone. There is a technique where you do a biplanar rotational correction and also can do some valgization, which is a very clever technique, but it's not in my skills. So I prefer at that time to just go in 2 stages during one surgery. I make a full cut, rotate, and then do varus valgus angulation. Now you have to realize that when you rotate, whether you internally or externally rotate, the frontal plane also changes a bit. And especially if you're not doing a pure transverse cut in the femur, the mechanical axis is where you have to go transverse to the mechanical axis. Then you do a pure rotation. So be careful if you do rotation osteotomies. If you do a rotation around the anatomical axis in the femur, you also will change varus valgus and even sagittal plane to a certain extent. And if you do large corrections, rotational, around an anatomical axis, you can end up with new deformities. So rotational osteotomies you do around mechanical axis. If you want to combine the rotation with valgization or varization, I would choose for lateral approach, opening wedge in shorter legs, or medial approach in, it doesn't matter what the length is.
Will the presence of a distal femoral osteotomy change the Q angle or change the TTTG or TTPCL distance?
Depends on a very good question, because that's something we osteotomies discuss about. If you look at what the trochlea is doing in your varus valgus distal femoral osteotomy, and in a biplane osteotomy, it's not doing much. And you have to look at the deepest point of the trochlea. However, if you rotate in a biplanar fashion, of course, the trochlea position changes. So you are changing at the femoral level, the TTTG. However, if that TTTG is changed to an abnormal position in the femur, you create a kneeing out or a kneeing in situation, patellar tracking. So in the femur, always correct to normal.
Yeah,
and
perfect.
tibia, you can play around with the tuberosity to normal.
Absolutely. Perfect. So thank you, Ronald. I think now we come to the last talk, which is probably the most exciting of them all. I think each one is more exciting than the other. And this is a problem that we've seen quite often. We look at all these malunited tibial head fractures, and Ronald is going to teach us how do we do an intrafocal correction for malunited fractures. Over to you, Ronald, please.
Okay. First, let me get to the share screen again.
Absolutely perfect.
So here we are. Now, this topic, we can talk until late in the evening, Indian time. So I have to make selections in this. And I've just thought, what can you face? And this is advanced osteotomy lecturing. So do not feel that, oh, this is just impossible for me. At the end of the slides, I give you some solutions, what to do if you think this is too difficult. But look at what the thought process is. And I've been very lucky to learn from a good teacher. My teacher was Professor René Marty, the famous AO surgeon whom I was happy to be a resident with. And I was also lucky to stay in contact afterwards and work together with him. And we wrote this book on osteotomies for post-traumatic deformities. There's a lot of intra-articular fracture malunions and intra-articular osteotomies. So I come from that situation, and you can find many of the cases I present here in that book. And as a resident, I saw these patients of Professor Marty. These patients came with malunited fractures, and they were still at an age where at that time he wouldn't think of putting in a knee prosthesis. So what he did was these kind of lateral monocondylar osteotomies with wedges inserted and also wedges in the fibular head, which at 17 years follow-up produced a knee like this. And at 22 years follow-up produced a knee joint like this. So what I learned as a resident was the long-term follow-up of intra-articular osteotomies, and that osteotomies work. Joint preservation with osteotomies, particularly in this field, work. So function is still at higher age. So that patient is 47 years old, 74 years old, 22 years follow-up after an intra-articular osteotomy, still doing fine. No question that she will ask for a total joint replacement. However, there are principles which are unique to intra-articular deformities. So you know from the previous talks of Dr. Clay and Professor Wilson about how we deal with the Paley principles and the measurements around the knee. However, if we have a malalignment caused by an intra-articular depression, we have a different story. There is no deformity of the shaft or metaphyseal area. There is an intra-articular deformity. And that intra-articular deformity causes leg malalignment because the depression causes valgus or varus, the other way around. It causes a joint surface incongruency. It causes instability, sometimes gross instability. And that's most important, if you do not treat them fast, there's a rapidly progressive osteoarthritis in these patients. So this is a group we should see early. Even if it's a failed fracture surgery, do them early because there's a rapid progression of osteoarthritis. So what's our aim? So the intra-articular osteotomies aim to restore the leg alignment. And sometimes you need an intra-articular reconstruction as well as a peri-articular osteotomy. So you add an osteotomy to your intra-articular osteotomy. We aim for joint surface congruency. If the congruency is not there, try to restore the congruency, even if you partially unload that compartment afterwards. We aim for joint stability, and we would like to prevent the progression of osteoarthritis. These are our aims with intra-articular osteotomies. So a malalignment intra-articular, you have to restore joint surface congruency. What from the tool set do I use? Well, I have these nice tools like a bend chisel. It's not a chisel, it's to push fragments forward, and I will show you what I do with that. This is another chisel where I can isolate depressed fragments in the joint, and afterwards with this instrument I can push that fragment out of a depressed position upwards to the joint level. I use K-wires for reference. These are the tools, and any of the other tools which help me with the correction I would use. Now let's look at some cases there. This is a young lady, I think she was 22 years old at that time. She came with a conservatively treated severe proximal tibia, medial as well as lateral plateau malunion. And she could only walk with crutches. She has a grossly unstable knee. And she was referred because they didn't understand what was happening there because her ligaments were intact on the MRI scan. However, your ligaments will only work if you have a congruent plateau. A plateau that's at the normal level. That causes the ligament laxity to be normal. And these ligaments even if they're intact, cannot work properly and cause a stable knee. She had instability because of a severely depressed lateral plateau, as well as a negative slope, and it's not so clear here. The picture has changed in format, but she has a negative slope. You can see that here at the medial plateau. So she has a lateral plateau as well as a medial plateau problem. What do we do with that? This is the lateral plateau intra-articular osteotomy. What we do, we open the joint. So this is there's no room for mini-invasive surgery in these patients. You have no reference. The medial as well as the lateral plateau is off. So what we do a tuberosity osteotomy and an arthrotomy. We open the knee joint for reference. Then it's easily to isolate the depressed fragment from above. Then we go with that curved chisel or curved instrument, and I make a hole through the tuberosity osteotomy area. So this is the anterior tibia after the tuberosity is taken off. And I push the depressed fragment upwards. I've seen cartilage still living 5 years after a depressed, malunited tibial plateau fracture. The cartilage is still living there. You only have to put it on the right place. So if you didn't do any harm to the cartilage in a depressed fracture, often you can bring it back to the normal level and then do bone grafting underneath with autograft or allograft bone to support the heightened part of the depressed plateau. So that's osteotomy number 1, lateral plateau. And of course, if the meniscus is intact, you can just lift the meniscus up for good visualization and not to harm the meniscus there. That's a different situation on the medial side. This sagittal saw I would normally use for a UKA, a uni knee. Now we use it after we have cut the medial meniscus intermeniscal ligament. We use it to make a cut there because we want to lift that medial plateau upwards to the normal position. And here you see that. We have a spreader in. That spreader levels the medial plateau to normal. We put in a graft, an allograft, after we've leveled it to normal. And then we fix the whole construct. We fix it from medial. This patient will be on partial weight bearing 6 to 8 weeks. We have refixed the tuberosity. And this is afterwards. And just to show you with CT scan, 3D CT scan slides, these plateaus are normal. This patient immediately has a stable knee afterwards, after such a reconstruction. She's functional in the rehab, other than that we protect her with crutches. And she ends up with a fairly neutral alignment afterwards. And she has all her ligaments intact, and now she has a stable knee, and she has a good prospect with these very severe injury, and you do preserve the joint with that. And this is not easy surgery. This is not all-day surgery. But if you plan this carefully, it's doable. You can do this. Now look at this. This is a case from Professor Marty. It's also in the book. This is a horrible, horrible fracture, but you will see that also in India with the road traffic accident. This is a form of fixation, but they didn't address the depressed plateau. So take out all the hardware and do an intra-articular monocondylar osteotomy, which looks like this schematically. Osteotomy here, osteotomy there. To make that smaller plateau, in this case, to a normal level, the cartilage was still alive, and then you graft it. And this was the end situation. And these were non-angle stable plates back then. But look at 20 years follow-up. This is 20 years follow-up of the same joint. And this is function. of that same patient. 20 years follow-up, still functioning joint. It's in slight varus. The medial plateau is still no joint space narrowing, and that lateral is intact out of such a fracture. So this makes you a believer in why you should try to preserve these joints. Now, this is daily, nowadays surgery, and some of the companies have very good PSI systems. This is courtesy of Adrian Wilson, my colleague at the London Knee Osteotomy Center, and he here did a PSI guided correction with a custom-made plating of a oblique lateral hemiplateau osteotomy and a lateral open wedge HTO for a biplanar deformity. And this, the companies can help you with that. Nuclip company has a perfect system with PSIs. They make these plates, whatever you want kind of plates, custom made. As a company, they have originated around PSI. This is from another company, same result. You get guides where you make your cuts, and then you have these kind of instruments to help you, and these tailor-made plating. However, this is not my all-day practice. I have to do it with proper planning, good preparation, and then use simple tools and grafts. And that's how I do it. But this is a perfect way to do very accurate corrections. And if you can do it like that, it's very beneficial for the patient. Now look at this, the importance of alignment. This is courtesy of my good friend, Philip Lobenhofer. In Germany, they do not have access to allografts. So find yourself an autograft which resembles a malunited, totally destructed lateral plateau where you cannot do a intra-articular reconstruction. So this is incongruent, it's depressed, and the cartilage is severely damaged. So then you cut out, first you remove the screws, you cut out the upper part, and you replace it with an allograft. So this is not reconstruction with the own tissue, other than this is iliac crest graft, and that resembles the cartilage surface of that lateral plateau. And this big gap is filled actually with a very nice graft, and this looks like a normal joint surface. So this is a very nice example. If you do not have the ability of allografts in your country, how you can manage with an autograft which is inserted to replace that defect and to restore joint congruency of the lateral plateau. Now, this is after. Look at this very nice lateral plateau and also the lateral joint space. Look at this arrow because it becomes important in this patient. So a very nice reconstruction, very original, but this is 6 months later. Look at the joint space narrowing. The joint space narrows. The patient gets valgus and it's overloading the graft. What's happening here? The alignment was off. So the alignment was in valgus, and better to protect your graft and put that leg into neutral or varus. That was, of course, what such an expert like Professor Lobenhofer did, immediately correct the alignment, and by that, medial closing wedge varisation, unload that graft. And what I heard of, this knee is still preserved after this very original reconstruction. Now, I see cases like this too. This cartilage, and I point here at the hole, has been cooked because of a bone substitute which develops heat when you put it in, was put in a defect, and then there is no cartilage living there anymore. There's a big hole, and there is valgus, and there is pain in a patient which has a destructed lateral plateau. there is no way I can do a lifting of that plateau, which will lead to something which lives there. So what do I do? Here I go for an allograft reconstruction. Lateral tibial plateau, fresh frozen allograft reconstruction, and an unloading lateral opening wedge HTO. This is how it looks like. I order a match-sized proximal tibia allograft from the bone bank. I cut out the remnants of the lateral proximal tibia, and that leaves a huge hole there. This is a very strange X-ray because a lot of bone is missing here after the segment resection. Out of that allograft, I match and I measure, I match out of my preoperative planning an allograft piece of bone to put in and to fix in that same space. And then I'm still at the valgus position, so I don't want that. So I have to add a lateral open wedge to unload that allografted part. So that reconstructed part of the lateral plateau. That's what I did. So this is the post-operative situation. We have a congruent joint. We unload this part by the lateral opening wedge. This is the side view. This is the weight-bearing axis. Actually, this is a little bit too medial because that's just how the line is dropped in that in the PowerPoint. It is actually a little bit more medial, but it doesn't cross midline. So she's walking more medial than on that reconstructed lateral compartment. This is 2 years follow-up, an arthroscopic view when I took the hardware out. And of course, it's not normal cartilage on the outside, but it's a preserved joint. And she's doing well at that stage. Later on, she gained a lot of weight, and that I couldn't do anything with that. And she had to go for a total joint replacement, which, oh, I hated it. But anyhow, she could have survived, I think, if the weight wouldn't have been gained afterwards. This is a case we did recently in the London practice. Same situation. This patient is walking on his screws for many years now. He has excruciating pain during walking in severe varus. This is not a part of a medial part of the joint, which you can reconstruct. So we go for fresh frozen allograft with an unloading medial opening wedge osteotomy. So this is where we are. We put in K-wires for reference. We take out a big piece of bone, which is, after we take out the screws, which is just remnants. It's not functional, it's not vital. Then we have the allograft. We size up, we take a big piece, this is the piece we have, we fix it in place, and then we do a opening wedge underneath that. This is how it looks like afterwards, and this is the leg alignment. And I have to be honest, this wasn't, although it looks like valgus, and the patient was very happy at that stage, when we made the full leg weight-bearing X-ray, the weight-bearing line passed neutral to slight varus. So my colleagues, Professor Wilson, Adrian Wilson, and Ragbir Kaka, performed a slight lateral closing wedge distal femoral osteotomy to put that weight-bearing line into the lateral compartment. And this patient's extremely happy with this new situation. So this is how you can deal if you can use allografts in such patients. Now look at this last case. This is a different situation. This is a congruent depressed plateau. For me, I cannot do a lifting procedure because it's the whole plateau. It's not a segment. So what do I do then? She has 14 degrees of valgus because of this. And she has a congruent depressed plateau, multi-direction. What I do then in this valgus overload situation is I do a straightening procedure of the leg, an unloading realignment osteotomy. So she has an MPTA of 100 degrees, which is abnormal, and which is consistent with the valgus abnormality of the whole leg. This is how she walks. She's a young lady. She has valgus. She has some extra scars because this was a skiing accident and she had a compartment syndrome, but they were very good in the decompression, so she doesn't have any neurovascular damage. But this is not nice to walk with, and she has pain during her walking. Sagittal plane is normal, flexion is normal, and this is manipulation into neutral. So if you examine her, you can straighten her out of the valgus. Out of that came this idea. An osteotomy, first releasing the nerve, because she was in that valgus post-traumatic situation for a long time already. I released the nerve. And then I went for a lateral opening wedge high tibial osteotomy. So the whole depressed, congruent depressed fragment, I put upwards, lateral open wedge. So here we have the spreader in. And I measure because I pre-planned how much I had to open it. And this is the case, what you're doing. And this is how stability is regained on the lateral side. Now, I took iliac crest autografts to insert in that gap. And then comes a funny scenario. Because this is intraoperative, I've put the wedges in. And then this is the post-operative X-ray. Something is missing here. What is missing is the plate. You do not need a plate in such a case. If the hinge is stable, this puts so much force while inserting these wedges. And this is a very compliant patient, so I didn't do a plate. And this is post-operative situation, 3 months after, leg alignment 3 months after. This is walking pattern 3 months after. Full bone healing and a very happy patient. So take home messages on the intra-articular osteotomies and the malunited fractures. Intra-articular deformities cause leg malalignment. They cause joint surface incongruency, instability, and rapidly progressive osteoarthritis. And they can be treated with intra-articular osteotomies, auto and allograft reconstructions, and unloading realignment osteotomies. Please, these patients, preserve their joints. Metal and plastic is the last way out. And especially for your young patients, don't start with that. Give them a chance. And remember this 20 years follow-up patient, because this is an extremely good result for such a kind of surgery. Now, some closing remarks for advanced osteotomies as a whole. Because should you do this yourself? If yes, of course, go for a proper analysis. Think about this surgical planning. Prepare with all the instruments you need and all the tools you need and all the help you need, and then perform your osteotomy. Or do you need to refer this patient? To where do I refer this patient? Also in India, also in practices like Dr. Sachin Tapasvi and all the other practices. They're experts. They know what they do with it. And otherwise, you can also refer abroad. We have centers for advanced osteotomies. In the London Knee Osteotomy Center, we treat cases like this, the complex cases. And these are some examples. This is a 2-plane double-level osteotomy in a Charcot-Marie Tooth patient who had valgus and hyperextension. He needed an orthosis like this to be able to walk. And he's a sportsman. He doesn't like that. So we did a double-level correction. This is frontal plane, and this is sagittal plane correction. And this is angle stable fixation on the medial side. And this is what you know. This is a flexion osteotomy. for his hyperextension deformity. And he has some hyperextension on the other leg, but he's very stable and very happy with his realigned leg on the right side. And these are just some of the other complex osteotomy cases we do there in that center. And that's an X-ray to show what it is. I thank you for your attention. This was a very long session, and I hope it was worthwhile listening to it.
Thank you, Ronald. I think we cannot overemphasize how useful it has been for all of us. It was so spellbinding that I think probably people are scared to ask you questions on this last presentation that you had. I actually have two comments that have come in criticizing me that you were wrong in sort of saluting him that he is a magician. You should actually call him a god and not a magician. So there are two messages that have come through, and they've sort of really criticized me. But yes, I think I do agree that he is certainly the god. But most important of them all is the way he makes it sound so easy for us, in the sense he has such a crystal clear understanding of all concepts, is that the whole approach, I think, in it makes itself very, very, very palatable and very easy for us to digest. Also, I think what is really very important for us to understand is that, what are the things that I can do and which I can't do, because I'm sure we really don't want to do the things that we really are not able to do. Any questions, Nilesh or Sandeep, do you have any questions on this? If not, there are two questions which have come up here, which I'm going to ask. Right. So, Ronald, question number one is that in the case that you showed where you did a double osteotomy on the lateral tibial condyle, essentially for, in which there was a split depression only of the lateral tibial plateau, why did you do a double osteotomy? Could you not do it through a single osteotomy?
That case was a case of professors, and that had to do with the tibial plateau with the fracture fixation had become smaller. So the mediolateral distance was smaller than normal. And to create some kind of congruency, you have to broaden that. So that was why the second cut was necessary. Yeah.
Okay, so I've got an experience of maybe 4 or 5 such patients who've had a split depression, and the lateral tibial plateau gets splayed open, as the whole femur sinks, it gets splayed open. And on a couple of times I had to actually reduce the width of the lateral plateau by removing a piece of bone and reattaching and retensing the lateral sided structures.
Very good, very good, very good action. And then what I would do in such cases, what I would advise to create what we call an open book. You can just take out, you open that bone, you take out the slice and you compress it again. Then you have a normal width again of the proximal tibia.
What about the situation where you sort of showed the first case where you had to do, an elevation of both the lateral and the medial side? Why is it necessary to do a tibial tubercle osteotomy? Is it mainly for exposure or for other reasons?
It is for exposure in that particular case because the depression was almost 3/4 of the lateral plateau from anterior to posterior. It's very difficult without kind of releasing the fibular head to release all the lateral structures to have access to that area. That's the first, because you have to realize we do not do anything with the anterior or posterior cruciate ligament. You have to have access. Yeah. So that was one of the reasons. And again, there is no reference in that patient. I cannot refer to a medial plateau when I'm doing the lateral plateau. So that was particularly difficult in that case. But there are, of course, surgeons who are very good in more mini-invasive approaches and are very skilled at that. And I've witnessed, for example, my colleague Christian Klei do magic on the millimeter, I call it. But for me, I need this. And if I do not endanger the wound healing situation by it, I prefer to do it like this.
One more question. Actually, this is probably a situation which I faced once. Another similar patient with badly depressed malunited lateral tibial plateau fracture with injury to the meniscus and loss of meniscal tissue as well at the same time. Looking at your presentations and your cases, would it be wrong or would it be possible actually to take or order a meniscus allograft transplant? It usually comes with its with a hemi portion of the lateral end of the tibia, and then can we transplant it as a composite, the allograft bone along with the meniscus, and put it back in? Would that be a feasible option that you would be happy to try?
Yes, but it adds to the complexity. You would think it would be easier, but now we're talking about a situation where the full anterior to posterior part of the lateral plateau or medial plateau should be taken out.
Yeah.
So I've been showing, which is most often the case, it's half of the plateau or a segment like that. So in my experience, meniscus may be captured in fractures and can be released from that. Meniscus are often preserved, but if they should be cut or partially cut and cannot be replaced, it's the more reason to do an unloading osteotomy together with your intra-articular reconstruction, because that part of the knee is in danger even after you've done your perfect reconstruction. Yeah.
Excellent, excellent. Any more questions from the panelists? If not, I'd like to make some closing remarks. I think, thank you, Ronald. You're truly the god of osteotomy and realignment. And absolutely, I mean, there are messages. I can see there's Matthew Olivier who's sort of saying hi and fantastic presentation. So there are so many messages that are pouring in. For all the viewers, I'm sure you would want to, at least I want to go and revise these talks all over again. So thankfully, our colleague here, Dr. Sandeep Biraris, will have this posted on the Pune knee course website for all of you who would like to go and look at all those talks one more time. We've also uploaded the previous talk, which was delivered by Adrian and Christian as well as all the other webinars as a part of Pune knee course. And Ronald, I'm sure that someday in the next couple of months when things are quieter, we will all travel and see each other, and we are eagerly waiting to welcome you to Pune one more time. Pune knee course will be more than happy to have you over every single time, because we get to learn so much from you every single time. So friends, I think I'll sign off. Thanks to Anshu, thanks to Parag, thanks to Nilesh, Sandeep, and of course Ashok, and thanks of course to Ronald for staying behind for 2 hours and 45 minutes. So I think that's completely unbelievable. I think your throat must be parched and you must be really tired. Christian Clay also says thanks to you, so does Greg. So a lot of our friends tuning in from all across the world. Ashok tells me that we have over 5,000 visitors for today's webinar from everywhere, from Southeast Asia to the Middle East to East Europe, to our friends in Europe as well. And maybe Ashok will give us some stats later on. And it was absolutely fantastic. So Ronald, do you want to make any closing remarks before we sign off? I mean, you can always make the remark that let me off now, you've squeezed me enough, but still all the same. I hope you enjoyed it, because we thoroughly loved it.
Well, thank you so much for all your kind words. And time travels fast if you're having fun. And for me, it's a privilege to be able to talk extended on topics I really, really love and I'd like to teach about. I'd love to come back to Pune live, doing live surgeries, or meet all the participants once more and answer the questions that are left over. Thank you for the opportunity. Thank you, team of Pune, for a perfect webinar organization like this. And I'm going to tune in for the other webinars to come. So thank you again, and have a nice evening, night over there in India.
Thank you so much.
Okay.
Thank you. Thank you. Thank you, Ashok. Thank you for everything.
Thank you.
Thank you so much. Bye, Ronald. See you.
Bye-bye.